Imagine you have a patient with a history of Hep C as well as liver cirrhosis who's presenting to the hospital with hematemesis as well as melanoma for the past few days. After you've had a few seconds of panic, what do you think is going on? You probably realize this patient likely has varices from liver cirrhosis, and that these varices are now bleeding, which is not good. The question now becomes, what in the world do you want to do to manage a patient with an active variceal bleed? A good way to think about variceal bleeding management from start to finish is to subdivide it into 3 different types of management: general measures, specific measures, and lastly, secondary prophylactic measures. Let's first talk about general measures, which are more or less things to stabilize your patient hemodynamically. You should first bring your patient to the ICU, where he'll have proper treatment options and monitoring. You also need IV access with at least 2 large bore IVs, 1 in each arm, so that you're able to provide blood products, medications, as well as fluids. Your patient will likely need to be intubated, as he is at a high risk of aspirating blood into his lungs, which is not fun. Once this is done, you want to monitor the patient's vitals, especially heart rate as well as blood pressure, as well as provide any fluids or blood products as needed. Generally, you want to make sure that the patient's hemoglobin is above 8 in the setting of a variceal bleed. Lastly, it is also recommended that patients with variceal bleeds be put on short-term prophylactic antibiotics. Part of this is for the increased risk of spontaneous bacterial peritonitis, or SBP, in patients with liver cirrhosis. But another part of this is the theoretical high mortality of an overlapping infection on top of an already dangerous variceal bleed. Oral norfloxacin is the preferred treatment option if your patient can tolerate oral medications, but most likely your patient can't, and so you'll need to give either IV ciprofloxacin or IV ceftriaxone instead. The recommended length of antibiotics is 7 days total. But as soon as your patient can tolerate oral medications, you can switch him from IV to oral antibiotics so that he doesn't have to stay 7 days in a hospital just for antibiotics. Now that we've talked about general measures to stabilize our patient, let's move on to specific measures to control the active bleeding. I want to stress here that even though beta blockers are first-line meds for prophylaxis against variceal bleeds, they should not be used in the acute setting, as these can decrease an already low BP as well as blunt your body's appropriate cardiac response. In the US, the most definitive treatment for an active variceal bleed is the combination of an octreotide infusion along with endoscopy with either variceal band ligation or sclerotherapy. Just to remind you what causes esophageal varices. When you have high pressures in the portal vein, this pressure is referred to the veins that lead to your esophagus, and it is the presence of high pressures in the venous system around the esophagus that causes the creation of varices. Octreotide causes splanchnic vasoconstriction. This decreases the flow of blood in the portal vein, which also decreases the pressure in the portal system. This decreased pressure is then referred to the veins around the esophagus. And it's not too hard to imagine from here that with less pressure in the varices, that there will be less bleeding. The octreotide infusion should be given for 3 to 5 days. The other half of the recommended treatment is endoscopy within 12 hours of hospital admissions, with subsequent sclerotherapy or variceal band ligation. Sclerotherapy is a fancy way of saying injecting something into the varices that causes it to shrink, and variceal band ligation is a fancy way of saying putting tight rubber bands around the varices. The combination of octreotide and endoscopy is usually effective in stopping bleeding, but it does fail in 10 to 20% of cases, as evident by sudden drop in hemoglobin, symptoms and signs of shock such as tachycardia or hypotension, or obvious signs of continued bleeding such as bright red blood in the NG tube after the procedure. In this case, panic. Then think about your other options, which includes repeat endoscopy, TIPS procedure, as well as surgery. In the interest of time, I won't talk about these in detail here. Instead, let's assume our patient, like 80 to 90% of patients who undergo octreotide endoscopy, stops bleeding, which generally means a 24-hour period with no signs of active bleeding. What do you do then? Do you just send your patient home, pat yourself on the back, and call it a day? This is where we talk about secondary prophylactic measures. In patients who have their first variceal bleed, there's a high rate of rebleed as well as death afterwards if the patients are not managed in some way. For example, the median rebleeding rate in untreated patients is 60% within 1 to 2 years of the first active hemorrhage, and the mortality is about 33% in that same population in the same time frame. Now that's pretty scary stuff, which is why the patient will need secondary prophylaxis. It is recommended that patients be placed on a non-selective beta blocker, such as propranolol or nadolol, as these in theory help decrease pressures in the varices and hence prevent against rebleeding. For patients that had incomplete obliteration of the varices during the acute episode, repeat endoscopic band ligation is recommended every 7 to 14 days until the varices are completely obliterated. Afterwards, endoscopy should be performed in 1 to 3 months to monitor for a recurrence of varices. After that, you can lengthen the periodic endoscopy to every 6 to 12 months for monitoring of recurrence. For patients that rebleed multiple times, you have to more strongly consider a TIPS procedure as a treatment option. Now, that's all the time we have for in this video, so let's get to our take-home points. Please take a few seconds to pause and read these over yourself, and our sources are also listed for your reference. Thanks for watching.